Okay, it's time to get started. So hello and welcome everyone to the COVID-19 Vaccine Safety and Immunization Monitoring Challenge final event organized by ADB partners and Agrise. I hope everyone's having a good afternoon, good morning, good evening, depending on your time zone, and I hope you're excited to get started. So it has been a little over a year now since the COVID-19 pandemic hit us, and all of us, I think, are now hoping to return to our normal lives as soon as possible. Now, with the new ray of hope, thanks to the development of several vaccines, such a challenge as what we are offering right now is essential, as the goal is to find solutions to monitor and track the distribution of these vaccines. The aim of this challenge and the reason why we launched it is to find solutions to boost COVID-19 vaccine demand, help dose tracking, and potentially monitor mild and adverse events following vaccination, and also to help individuals, health providers, and governments track who has received which vaccine and which dose of the vaccine. And my name's Sarah Hearn, and I will be your host for this final event. It's always a huge pleasure to learn firsthand about our innovators' interest in innovative new solutions, and I can't wait to see what our top 4 finalists have in store for us this time around. And before we get started, let me give you an overview of today's agenda. So first, I'll be briefing all of you on the challenge overview, the judging criteria, and introducing you to the judges. Following that, we'll have a pitching session by our 4 finalists, followed by 20 minutes of jury deliberation. And of course, remember to stay tuned for the award ceremony, which will happen immediately after the jury deliberation. And now, before we start with the figures and the stats of this challenge, I'd like to introduce Mr. Patrick Oseve, who is Chief of the Health Sector Group at ADB and who will be providing some opening remarks. So Patrick, when you're ready, the floor is yours.
Thank you very much, everyone. It's my pleasure to welcome you to this final event for the Digital Against COVID-19 Hackathon Challenge, which is hosted by the ADB Health Sector Group. This challenge is quite timely, but extremely important as we embark on one of the largest and perhaps the most complex immunization campaigns ever seen in recent history. As COVID-19 vaccine becomes available, ensuring sustainable vaccines distribution, tracking, and delivery is critical. However, successful COVID-19 vaccine rollout requires multiple components to fall into place. I just want to name a few so that you see how complex this is. People need to access accurate information in a timely way. To be able to at every site regarding where they should go for vaccination. They need to know what vaccine they are getting, and they need to remember to get the second dose. Sometimes 21 days later or 28 days later. Health providers also need to keep track of which vaccine they have administered so that they can provide the patient with the second correct dose. And more broadly, countries need to establish strong distribution network and strengthen health system capacity so that the poorest and the hardest to reach have access to this life-saving vaccine. So today we have 4 great finalists. We have Reach 52, who will share their integrated e-health solution for tracking COVID-19 vaccination in low-resource, rural, and offline. Second, we have Simprints, which they will show how biometric technologies can be used to verify COVID-19 vaccine doses that reach the right people. Third is Empower plus United Purpose, which will bring to us mobile health prevention awareness and telemedicine systems that leverage rural women entrepreneurs to build community preparedness for vaccination. And finally, Johnson & Johnson Global Public Health will share their vaccination monitoring platform that supports vaccination campaigns at scale and ensures correct administration of the second dose. So we look forward to a very successful session, and thank you very much.
Thank you very much, Patrick. So now, before we get started with the actual pitching session, let me share a few key figures about this challenge, which was launched on December the 4th last year. So we're really impressed with the interest and active participation that this challenge generated. As you can see on this slide, throughout the application phase at the beginning, we managed to gather 367 individual participants that were regrouped in 181 teams. And today we'll be seeing the top 4 of these initial 181 teams compete for the seed funding. So to all the teams who participated, we're truly grateful for your active participation and your submissions. And please know that just by having managed, going through this rigorous process to get to where you are today, you are already a winner. And you've also contributed to solve a very, very important challenge in today's life. Now for the pitching format. So all the finalists will be given 15 minutes to pitch, and then it'll be followed by a 15-minute Q&A session with our judges. We will be timing you, and you will hear a bell ring when you reach the 14th minute mark. And then I will stop you at the 15th minute to ensure that everyone has a fair time for the pitching and the Q&A. So please make sure that you stick to the allocated time. And then again, for the judges, as a reminder, feel free to use the raise hand feature when you want to ask a question, so I may know who wants to ask a question, else I will attribute randomly someone. Then for the judging criteria, the projects today will be judged based on the 4 criteria that you can see here. So we have potential positive impact for 30%. We have operational feasibility and scalability for 30%, which is the viability of the solution to be implemented. We have user experience for 20%, how easy is the solution to actually use for the end user. And then technical competency and innovativeness for another 20%, which are the features of the solution provided. Again, the jury deliberation will be held at the end of the pitching session. And now, what can you look forward to in the event that you were selected today? So the selected solution will have a potential funding of $50,000 or more to pilot their solution in ADB's developing member countries. So I hope you're looking forward to that possibility. Now, I would like to introduce our amazing panel of judges today. It's a pleasure to be working with all of you, and thank you for participating in today's event. I would like to request each of you to give a brief 30 seconds, 1 minute self-introduction and greeting when I call your name. So first of all, we have Julie Kay, who is VP Sustainability and Executive Director at Click. So Julie, please, the floor is yours.
Yes, hello everyone. I am Julie Kay, and I'm based in Boston, and I've been working with Click for a number of years. And for those that don't know who Click is, we're focused on providing analytic solutions and software for the use of data. And so we've been involved and very proudly involved with partners like ADB in using data to help foster decision-making, and very excited to see the solutions this evening.
Thanks a lot, Julie. Next, we have Patrick Oseve, who's just given the opening remarks and is Chief of Health Sector at ADB. So Patrick, please go ahead.
Thank you very much. Patrick Oseve, medical doctor, public health specialist and epidemiologist. And I work at ADB, working closely with the Health Sector Committee to program ADB health resources. Thank you.
Thank you, Patrick. Next, we have Mark Landry, who's regional advisor for WHO. So Mark, please go ahead and introduce yourself.
Great, thanks, Sarah. Yes, I'm Mark Landry. I'm the regional advisor for health information systems with WHO in our Southeast Asia regional office, sitting and based in New Delhi, India. Working with member states in this region and having worked in Asia for the last 11 years. Very exciting to see a lot of phenomenal innovation happening and in my work supporting countries with their digital health solutions to support better achievement in health outcomes. So congratulations to everyone who's gotten this far. All 4 of these finalists, from what we've seen already, just look outstanding. So really excited to learn and hear more from the pitches, and good luck to all. Thanks.
Thank you, Mark. Then we have Patrick Seelborn, who's Regional Advisor Asia for Pandemic Action Network. So Patrick, go ahead and introduce yourself, please.
Thanks, Sarah. Yes, so Patrick number 2, but neither of us is from Ireland, just to clarify. I have a long background in global health, having worked sort of 10 years for the Global Fund and the last 4 years with Asia Pacific Leaders Malaria Alliance, where I headed up external relations. And earlier this year, I became the regional advisor for Pandemic Action Network. Really looking forward to hearing from all of you today. Super exciting solutions. Thank you.
Thanks a lot, Patrick. And last but not least, we have Andrew Schroeder, who's Vice President of Research and Analysis at Direct Relief. So Andrew, please take to the floor.
Thank you very much. And I would echo everyone in saying that I'm looking forward to hearing all of the projects that have been put forward today. Direct Relief is a global nonprofit organization. We specialize in healthcare logistics, distribution of essential medicines and medical supplies in 90 countries, and have been supporting in a number of different facets of the COVID-19 pandemic throughout the world since January of last year. So I think all of these projects look like they have the significant potential to make a high impact on the vaccination campaign. So congratulations to all of you. Thank you.
Thanks a lot, Andrew. So thanks again to all our judges to be present today. And now it's time for our finalists to present their ideas, and may the best team take it home. So the pitch in order for today will be: first, we'll have Empower plus United Purpose. Then second, we'll have the J&J Global Public Health team. Third, we'll have Reach 52. And last but not least, we'll have Simprints. So good luck, everyone. Empower plus United Purpose. You may share your screen and start when you're ready. We will start the timer. Good luck.
Thank you. Hopefully this is now visible for everybody.
Yes, it is.
Great. Well, hey, everyone. Thank you for having us. I'm thrilled to be here as a representative for a wide network of women and colleagues across Bangladesh, working tirelessly during this pandemic. My name is Connor Steele-McCutcheon. I am the Program and Partnership Development Manager for United Purpose Bangladesh, based in Dhaka, and I am joined here today with my colleagues from Empower, Mridul Chowdhury, who is the CEO and founder of Empower, and Zaki Haidar, who is their Program Development Manager. A bit of background on who we are. United Purpose is a UK-based NGO with more than 25 years of experience in Bangladesh, working with women and vulnerable communities to move beyond aid. Alongside the more than 3 million people we work with across Bangladesh, UP provides technical support and programming expertise to jointly strive towards achieving the Sustainable Development Goals on terms that are relevant and impactful for our community partners. Empower is a social enterprise which utilizes a human-centered design approach to develop ICT solutions, information communication technology solutions for community development in Bangladesh and internationally. Its digital health solutions are used widely in Bangladesh and other countries to enable a grassroots approach to One Health and last mile program delivery. We're excited to present this project here today entitled Mobilizing Rural Women Entrepreneurs for COVID-19 Vaccine Awareness and Monitoring in Bangladesh, a continuation of UP and Empower's innovative collaborative work in community-driven tech solutions, which now seeks to ensure that the most vulnerable and under-resourced communities in Bangladesh get the same level of COVID-19 vaccine understanding and resource as the rest of the country. Our proposal involves leveraging an existing network of women's business centers across Bangladesh, which are operating an established women-facilitated telemedicine service during the pandemic for vulnerable members of their communities. These entrepreneurs will use the mobile-based outreach application Corone Coronio, which is Bangla for what to do during Corona, to prepare vulnerable and under-resourced communities for COVID-19 vaccination campaigns, dispel dangerous rumors, and address concerns related to potential side effects and follow-up doses. In the first 3 months, 240,000 of the most vulnerable and under-resourced individuals will be reached through this platform with clear and accessible information about the vaccine and where and how to get it. By the end of 2021, that number will be 2.5 million. In understanding the need for this approach, we are highly attentive to the existing high-level awareness and preparation programming being conducted by the government of Bangladesh and others. We are also attentive to the risk created by a top-down approach to behavioral and science communication, which can leave the poor and illiterate alienated and unvaccinated. The unique value of this proposal is the ways in which it closes gaps in this, reaching the most vulnerable members of communities across the country who may otherwise be passed over with information that means something to them. So this value includes integration with an existing women-facilitated telemedicine program, which is currently funded by GIZ, and which has placed remote medicine and COVID-19 prevention information in the hands of thousands across the country in accessible terms, delivered by trusted intermediaries, which are the Women Business Center entrepreneurs. I'll get into how the vaccine information maps onto this existing service in a moment. But the key is that the proposed tech solution is being placed in the hands of women who have built a trusted presence in their communities as a source for accurate and understandable COVID-19 information. This existing connectivity is what enables the project to reach scale so quickly, as well as meaningfully communicate to households who may not be reached by centralized or text-based mass awareness campaigns. This is achieved through the existing awareness activities being conducted by women entrepreneurs who are building hygiene and infectious disease prevention awareness in their communities, through one-on-one engagements at their business centers and through courtyard sessions. There is significant economic incentive for women entrepreneurs to promote this information as a means to ensuring sustainability and broadening the customer base for the Women's Business Center service and product offerings, which include primary care consultations with DACA-based doctors and the sale of locally produced masks, soap, and other related products. Altogether, this enables a unique kind of community ownership of vaccine awareness and accurate information, which will radiate beyond the direct catchment areas of the WBCs and is essential given the scope of misinformation and mistrust circulating around the vaccine globally. So this is not a new process for United Purpose. We've spent years developing this approach in partnership with the WBC entrepreneurs to deliver nutrition information, agricultural information, social cohesion programming, and health information. In each case, entrepreneurs with the technical support of United Purpose have run with this information to expand their service and product offerings to meet the new demand created by this programming. So it is precisely the strength of these grassroots efforts that give this project the capacity to meet the scope and required of this initiative. Empower, which has extensive experience working with United Purpose and the Women's Business Centers, has developed the Coronae Coronio app in this context, tailoring it to the needs, capacity, and contextual factors of the WBC entrepreneurs. This embedding within the WBCs has made the current iteration of the app, which is already being used by women entrepreneurs, a success, and it positions the COVID vaccine plugins for rapid deployment. So a bit about how this works. Women entrepreneurs are deploying currently the Coronae Coronio app in their community in a range of ways, including satellite camps, individually through their center, and in courtyard sessions as an intermediary between the platform and those in the broader community. These sessions are important tools for generating awareness and behaviors which tie into business opportunities for the centers. And through these engagements, the entrepreneurs use Coronae Coronio to do a number of things, which include the dissemination of bite-sized social and behavior change communication materials linked to infectious disease prevention, the screening of suspected COVID-19 cases, and the generation of a risk rating in line with WHO guidelines, referral to government services for high-risk individuals, and integration of the patient registry with ClickHealth, which is the telemedicine platform that United Purpose and Empower are currently operating with the entrepreneurs to enable follow-up with at-risk patients. In order to integrate vaccination preparedness to this process, the proposed additions include multimedia information on COVID-19 vaccines, common questions, and ways to access the vaccine, and disseminated via one-on-one engagements, courtyard sessions, and SMS messages. There will also be integration of vaccination status and monitoring via the risk rating tool. Follow-up texts and calls regarding vaccine eligibility and scheduling will be generated from this database. And finally, reminder texts for second doses will be disseminated to those who have reported their first dose. The Coronae Coronio application has a range of features which the WBC entrepreneurs have been trained in. These include a fixed questionnaire triage system, which generates a risk rating according to WHO guidelines. It then facilitates connectivity with the government call centers, which follow up on high-risk patients to provide them information on how they can reduce their risk, where to access vaccines when they become available, and to facilitate scheduling. There's also integration with ClickHealth services so that at-risk patients can be flagged during a telemedicine consult. What we propose adding to this is COVID-19 vaccination information regarding locations and frequently asked questions. The collection of vaccination status of beneficiaries via the risk rating tool, SMS and voice prompts on vaccine availability, location, debunking myths, and vaccine rollout status, and multimedia content on social and behavior change and awareness for face-to-face health sessions. SMS reminders regarding second doses of vaccine also will be disseminated using this upgraded platform. As part of the registry network, the telemedicine platform ClickHealth will continue to support and amplify the impact of the vaccine preparedness communication So doctors are able to provide information regarding vaccination eligibility to patients based on their COVID-19 risk rating, and SMS and push notifications will send reminders to patients who have used the service regarding vaccine eligibility. For patients who are eligible, entrepreneurs will help them navigate the government's online Shuroka vaccination registration process and support them to follow up on their vaccination at the designated government site. The sustainability of the solution is built on several things: the established skill, authority, and business activities of the women's business centers. Each WBC is already equipped with and familiar with the tech resources necessary to run an awareness and information campaign, as well as the knowledge translation required to make this messaging accessible in vulnerable and under-resourced populations. WBCs are lifetime members of the communities in most cases and have been operating as business and information hubs for years. People not only trust them when they speak, they come to them for advice and guidance. Entrepreneurs are well-versed in the social marketing tools that generate market demand and will utilize these same skills here to promote the vaccination resources. Additionally, there's significant financial incentive for entrepreneurs to disseminate this information as it builds into their established revenue model, which thrives on integration and cooperative business. So the vaccine awareness and promotion campaign fits into the WBC business model in the following way. WBCs produce and sell a range of infectious disease prevention products, which they promote through trainings and SBCC materials on infectious disease prevention and hygiene. Simultaneously, they respond to gaps in the market, as with the doctor-based telemedicine care, providing affordable alternatives that are safe and accessible for vulnerable members of the community, such as women and elderly. The more they conduct outreach sessions and raise awareness on COVID-19, the more customers they generate for their infectious disease prevention products and tangentially their telemedicine services, which are already in high demand. The proposed project will leverage this existing model to incentivize vaccine awareness and promotion as another means of building the economic and social capital of the WBCs. So though the needs of the vaccination campaign will evolve over the coming year, the proposed project is adaptive by design to meet these new contexts. We plan to achieve this through its amplification of the women entrepreneurs' skill and knowledge brokering, as well as through our One Health approach to COVID-19 response and recovery, which in coming months will add televeterinary services and remote agricultural extension services to the digital offerings of the WBC. This will sustain the incentive structure critical to maintaining vaccine promotion until every last person is vaccinated, while continuing to expand the ICT skills of women entrepreneurs into new areas. When it comes to clearly explaining the benefits of the COVID-19 vaccine, managing communities' expectations regarding vaccine side effects, and not leaving people behind, women's business centers are ready as trusted experts who will bring the right information the last mile. We thank you for your consideration, and thank you to all of our team watching for your contribution to this proposal and this project. We now welcome your questions. Thanks.
Thanks a lot for your presentation. So it's now time for our Q&A session. So you can stop sharing your screen if you want, and our judges will now start asking questions. So does anyone have a question to start? Mark Landry, I see you have a question.
Great, thanks. Excellent presentation. Really intriguing use of apps and technology. So just help me understand for the Bangladesh context. I just happened to be on a call with our country office there yesterday, and thinking about in the context now that more than 4.5 million doses have been already distributed, and vaccinations have already underway. There's a very robust national deployment and vaccination plan. So how has this initiative been aligned with the government's micro planning and rollout of the vaccination? And then secondly, outside of the Bangladesh context, what is potentially transferable in terms of content and or platform solution for use in other countries? Thanks.
Thanks for that. In response to your first question, as part of the existing programming, which we implement telemedicine and COVID-19 prevention programming, those are very closely aligned with government activities, and at the local level directly involve Department of Public Health Extension officers and relevant government officials. When it comes to how we align with the overall vaccination campaign nationally, we recognize that there is a lot of really great work being done in this area, and that a significant number of people are being reached by this campaign. What we also know from our experience in working in these remote communities is that cell network does not penetrate into many of the remote CHAR areas and HAUR areas, and people are often reliant on word of mouth and other sort of informal pathways for information about the vaccine availability. What we propose here is not a parallel system. It is an integral part of the existing government system to reach that last mile to people who are not having access to this information, who cannot read potentially, who do not have access to a cell phone, and bringing that information to them in terms that are relevant and understandable through their trusted Women's Business Center contacts. I think when we look at other vaccination campaigns and infectious disease management campaigns that have occurred in the past, making sure that information about foreign things like vaccines is in local terms, that is understandable and accessible and not intimidating. We see there's an enormous importance there to protect that sort of local understanding of it and make sure that communities who don't understand it aren't turned against it. So we see ourselves as an integral component of that. In answer to your second question about scaling beyond Bangladesh, kind of how we see scaling is that scaling happens kind of one person at a time. Through satisfied relationships, understandings, and economies that spread confidence and trust. So every person that leaves a WBC courtyard session is a potential emissary for vaccine promotion to countless others. In a similar way, as an organization that focuses on grassroots programming like this, we see a tremendous potential for other organizations, other United Purpose Country programs who are operating in partnership with these community groups to emulate some of this model for dissemination and coordination. So in that sense, I think when we look at it from the perspective of nodes radiating grassroots awareness campaigning and vaccine promotion, that's how we think about this, both in Bangladesh at the full national level and also regionally and beyond. I hope that answers your question.
Yeah.
Thanks a lot.
Connor, yes. Yes, can I just add just 30 seconds of what Connor said? Yeah. So I mean, in answer to the first question about how we're aligning with government approaches, I mean, I would say that in addition to what Connor said, I mean, there are basically 3 key points that we're doing. One is that, there are about 6 to 8 million people who are living in Bangladesh in very remote areas, which are very hard to reach. I mean, getting to a government facility is about 2 hours trek from those areas. So we are focusing on those really hard to reach areas that government and even NGOs often find very hard to reach. The second is the risk rating that we're doing. We're sending that information through APIs that have been developed by the government. So essentially the government knows, where vulnerable populations are located in. The third is that we are helping these vulnerable populations register on the Surakha platform. Surakha is the government platform to register for vaccination. And a lot of people are not able to register because they don't have any internet access or smartphone access nearby. So that is the other thing we're doing. So that's how we're sort of very complementary to what the government is trying to do. Thank you so much.
Thanks a lot. And next, Andrew, I think you have a question, and Patrick, I'll get to you in a second.
Thanks very much. And I also appreciated your presentation. I'm wondering if you can help me to understand what the opportunities are in this platform for analytics off of the data on the transactional relationships with the women entrepreneurs. It seems like it's a fairly large user base, and you're talking about a pretty rich transactional set of engagements that could have ripple effect benefits in terms of understanding gaps, behavioral health factors, and a whole range of other things. Although I didn't quite see it in your presentation. Maybe if you could fill in some of the gaps for me on that, that would be really helpful.
Sure. Maybe Mridul, I can take a stab at the broader question, and then if you have anything you want to add.
Yeah.
In terms of the data collection here, so as I mentioned, there's the servers for the Coronae Coronial and the Click Health telemedicine application are combined. So as patients register for Click Health for their direct doctor consultations, their information is recorded within the system and linked to their unique phone number. Similarly, when people are conducting their risk rating process and entering their information there, their phone number is also recorded. So what we end up with is and what we are currently developing is a very broad network of telephone numbers linked with these individual identities that are then related to COVID-19 risk. So you can actually, from this, extrapolate the sort of high risk zones within the implementation area. And also, I think this, because of our integration with the government system, the government is also able to see this information, and it provides an incredibly important advocacy tool for these disconnected populations and under-resourced populations. I don't know if you want to add to that, Merdul, in terms of.
Yes, so as you were very correctly pointing out, we are actually ending up with quite a big amount of data. I mean, from the household, from the courtyard, from the people who are actually coming in for the telemedicine services, and we are able to correlate a lot of that information. And I won't get into details, but essentially on behavior issues, on risk rating, on who should be targeted more to make sure that they are actually vaccinated. So all of those things can be done, and the beauty of our solution is that we are often not talking about COVID directly, because we've seen that time and again that if you talk about COVID directly in non-health settings, it doesn't really register with people, because a lot of people in Bangladesh, in rural areas, and I think in other countries, don't really believe that COVID exists. So what we're essentially doing is we are bundling the messages of COVID in a healthcare setting. So when they come, because as I was saying, these are very vulnerable population who are not able to go to government facilities easily. So there is a very high demand for coming to our facilities for remote telemedicine services. So when they come in, they're essentially, because they're already sick and they're already open to getting health messages. So we essentially use that opportunity to put in COVID messages and also try to figure out, what kind of messaging actually works and for whom through different kinds of analytics. Thank you. Mm-hmm.
Thanks a lot. Next, Patrick Sewon, would you like to ask a question?
Yes, thank you. Thanks again for the presentation. Really interesting model using sort of women entrepreneurs to reach key populations. I guess one question I have is really, and I may have missed it, but the coverage across Bangladesh, you're focusing on hard to reach areas. Could you say something about the people you may be missing? Given that you're focusing on the clients potentially of the WBCs, do you risk missing other sort of key pops who may not be engaging with these centers? That's one. And the second thing is, in terms of geographical distribution, are there areas that you're missing? In that case, how do you propose sort of using the solution to reach those populations and those areas? Thank you.
Thank you. I think that's a great question. And I think one of the things about the WBCs is because they are focused on under-resourced settings, they may miss at a national level individuals in urban settings and resource settings who are disconnected from these services. What I will say though, in these under-resourced settings is because of how the WBC structure is set up, there's a strong incentive to reach into the households that have persons with disabilities in them, because the WBC is providing, for example, eyeglasses at a subsidized rate. So they're looking for people who are looking for eyeglasses, for example, or for single mothers who are struggling to make ends meet for their family. The WBC will partner with them to provide market outlets for their agricultural products, and at the same time then build a relationship which can promote things like COVID-19 vaccination awareness. So within the regions where they are located, they have a very high level of penetration into these typically disconnected or under-resourced individual communities and groups. The other thing I will just quickly add to that is part of their recruitment, part of how they work as a collective is to then recruit these people into the WBC as part of their cooperative enterprise structure. And so those people then radiate out further. And what you end up with is sort of a snowball effect that kind of saturates the entire area with the access to these services. And I'm sorry, the second part of your question was, if you could just repeat that.
Yeah, sorry. Yeah, so that's more about the geographical areas in Bangladesh you're covering and the ones you're missing. And how do you propose sort of reaching those missing?
Mm-hmm. Sure. So we focus on, like I said, some of the remote areas, the Char lands, the Howrah areas, the islands, and then some of the most remote regions of the Chittagong Hill Tracts, which you may be familiar with. What this model uses is kind of, as I mentioned earlier, in terms of how it achieves scale, is through this sort of centralized node approach. As this node becomes more and more robust, the radiation that goes out from those people becomes more and more effective. So each person who participates in the COVID-19 vaccine awareness session is then going out, and if they're talking to their friends about that session, the promotion that they give to a third party who is not present is going to be even stronger. As these nodes connect across the country, they do fill in these gap areas, even if there isn't actually a service in place. And in some cases, we've actually had a number of WVCs form independently in these gap areas, sort of filling in. So there is a process through which that reaches those areas.
Mm-hmm. And also, as I was saying, that we actually have this geographic mapping. So when people come into our facilities, I mean, we actually are able to map out on a Google Map based solution. So we see, exactly where people are coming from. And so we are able to locate where people are not coming from. So when we decide on the location of the next satellite health clinic, we know exactly which location to target. Yeah, thank you. Mm-hmm.
Thanks a lot. We have a little bit of time for one last question. So Julie, would you like to go ahead?
Sure, thank you. And thank you for the presentation. Just curious if you've done any analysis with regards to the mapping that you just referenced. As we know, all of the different vaccines have different cold storage requirements, making the challenge even greater in the distribution of these vaccines across remote areas. Have you done any analysis on how you kind of may plan for the different requirements depending on the vaccines that are actually brought into the country?
So thank you for that question. It's a really good one. In terms of how the government is deploying these vaccines, they are, to my knowledge, largely using hub and spoke model, where they have a centralized distribution point, and then we'll do day clinics out regionally from that point, because the cold chain becomes so difficult in some of these remote areas. We have not mapped how this works, largely because it is beyond our control at this point. That we do believe there's a strong capacity for advocacy. If we can demonstrate high risk levels in some of these remote communities, it may become easier to get the government to extend those cold chain systems to that area and ensure that there's a vaccination clinic. But in terms of beyond advocacy, we are sort of reliant on the government funding and capacity to reach into these areas. I don't know if you want to add anything to that, Mridul.
I think I can add something. This is Zaki from Empower. So
Zaki, please.
Right. So in Bangladesh right now, there is only one types of vaccine that is coming in, the Oxford vaccine. And the distribution network of this thing, as Connor has said, is completely governed by the government. However, because we are sending information regarding this risk rating to the government through an API, government actually can see this information in a large national scale solution and use that information to provide for resource mobilization and other kind of analytics that they use. So potentially they can actually use these solutions information and find out where there are more at-risk people and send more vaccines there if they want to use those analytics.
Thanks a lot for answering that. So that's the end of this Q&A session. And next team to go now is Johnson & Johnson Global Health Team. So please go ahead, you can share your screen and we'll start the timer when you're ready.
Thanks, everybody.
So I'd just like to check if you can see my screen correctly.
Yes, and we can hear you loud and clear. Perfect,
thank you. So thank you for the opportunity this morning of sharing our vaccination monitoring platform with you. I'd like to just outline how the presentation will be delivered. Firstly, I'd like to start with some background as to how we came about coming up with this current version of the vaccination monitoring platform. Our story will actually start in Ebola, but it's important to understand that the actual vaccination monitoring platform has been fully customized for COVID purposes. I'll proceed to then explain a little bit about the work that we've been doing with deployment of this platform at scale in Rwanda. Then I'd like to walk you through the separate components of the platform, and time allowing, I'd like to just summarize, so finalize the presentation with listing the characteristics of the platform as we see it. So I'd like to start by taking you to Western Africa in 2015. We had one of the largest outbreaks of Ebola happening at that time. And amongst the many efforts that were made by the international community, there was a consortium set up called EBODAC. And our team from Johnson & Johnson Global Public Health were a participant in this consortium. And the consortium had actually the mandate to develop strategies and tools to to improve the acceptance and uptake of Ebola vaccines when they would come to market. And our specific team's task within the consortium was to look at technologies that would support the clinical trials that were being used to evaluate the then candidate Ebola vaccine from Johnson & Johnson. That on the one hand, but on the other hand, we also aimed at in the longer term to have tools that could build local capacity and enable countries to help deploy a vaccine when it would come to market. So one of the first challenges that our team was met with when the initial trials were set up in Sierra Leone to start with was how to identify study participants, as the country did not have a systematic national ID card that we could use. So the team came up, as you can see from this slide on the right-hand side, the box showing a first-generation biometric kit. And in the kit, we had a binocular iris scanning device in combination with the digital fingerprinting tool. And what you can't tell from the picture of the box, there is also a laptop in here, battery pack, ink cartridges, etc., which enabled us also to issue a vaccination card. Now, this whole setup has proven to work very well, very robust. But the downside that we observed with this was, and it's maybe difficult to tell from this picture, is that the box is actually quite big, heavy, cumbersome, not very mobile. So as we moved to subsequent clinical studies that we needed to support, we really pared back the choice of hardware to off-the-shelf tablets in combination with the little external no-touch iris scanning camera. And the no-touch component to this is quite important because you need to realize these studies were being performed in the context of an Ebola outbreak. So we didn't want to be the reason for potential transmission of virus from person to person. So as you can see, our technology and our choice of hardware had evolved. Also, the regulatory status of our J&J 2-dose Ebola vaccine also had evolved, such that in 2019, the Rwandan FDA gave an emergency use status to the vaccine, and the Ministry of Health in Rwanda decided to set up a prophylactic vaccination campaign using the 2-dose vaccine and targeting a population of around 200,000 people who they considered to be at high risk of acquiring Ebola. Now, you need to know that these individuals are transiting into DRC, so Democratic Republic of Congo, for trading and work purposes on a daily basis. So Rwanda itself didn't have an Ebola outbreak, but Democratic Republic of Congo did. So hence the idea to try to protect this population. So the campaign was set up and our team was invited to provide support. And we were able to leverage the work that we had done in the clinical study setting. So what you see here on the left-hand side, you'll recognize the little handheld tablet and the iris scanning device being used by a field nurse in Rwanda. So again, we're using biometric iris scanning identification to really identify uniquely each of the participants in the campaign as they come for each vaccination visit. Now, we also evolved the tools that we were offering, and we built a database of reports on top of this biometric database. And these reports are available in close to real time. And you have different types of reports, either at a higher level management perspective, so that they can follow up really the progress of the campaign, how it's evolving. But there are also very detailed operational reports that are solely available to the clinical teams in the field, as it contains really detailed information down to the participant level. Then on the right-hand side of the slide, you see the lady answering her telephone. We decided to build a reach out component to this platform using mobile phone messaging, and we're using that to send appointment reminders or recall messages to the campaign participants' telephone. Now, this tool has actually proven in the context of Rwanda very useful. So when COVID came to Rwanda, basically what happened with the local restrictions, a number of the health centers who were involved in this Ebola campaign, they had to close down temporarily their vaccination activities. So we used the same mechanism to inform the targeted population about just practicalities around opening hours of the health centers. So not only for that purpose, but also the community liaisons, when they were picking up on questions or rumors that were happening in the community, that allows us also to use the same communication mechanism to send accurate information to address these questions out into the population that you're targeting to be vaccinated. So when we've deployed this in Rwanda, what's the experience so far? As the campaign is still running actually today, and the campaign has been supported with this platform for the vaccination of more than 180,000 people have received their first dose of Ebola vaccine. More than 132,000 have received their full regimens of dose 1 and dose 2. And the approach that we took to scaling this was a train the trainer approach. So really training up a first set of staff, and they then in turn training others, so that there are multiple teams using this platform across the various districts bordering the region with DRC that is being targeted. What we've seen so far is a very high degree of acceptance of the technology. And if you look at the gray box at the bottom of the slide, you'll see a quote from the principal investigator, Dr. Karita, who's responsible for the execution of this campaign in the field. And you'll see that this speaks to the value that he sees in the data and the reporting component, is this has really helped him in his obligations to report back to the Ministry of Health and the regulatory authorities on the progress of the program. So all in all, what does this mean in terms of completion rate? So how easy is it to deliver a 2-dose vaccine regimen in this setting? What we've seen prior to the arrival of COVID with the use of the platform is that we've had completion rates for the 2 doses of vaccine around the 98% level. And since the arrival of COVID, we see a slight drop in this to around 92%, but I think these are still exceptionally high numbers and something that the team on the field can be really proud of. So if we look at the components of the platform, I've already mentioned we're using iris scanning as a primary means of identification. But actually the platform does a lot more, and I'd like to explain that for you now. So for every person that's vaccinated, there is a record generated. We take a passport photograph of the individual who is to be vaccinated, and this can be used as a visual inspection tool once the person turns up for subsequent visits. So the operator can check, is the person in front of me the same person who had come in for previous visits. There is also barcode reading and QR code reading capabilities in the platform, and this is being used in the context of the campaign in Rwanda, as they've decided to use a campaign vaccination card, which really equates to a unique identifier. So your starting point can also be, if you're not using iris scanning, you can use this as well. You can scan this in and really identify the person on the basis of their card. The other application of the scanning capability is we also read in the national ID card if a person has their national ID with them. And if you don't like any of these entry points into the platform, we can even use just a simple manual entry of whatever has been agreed as the participant identifier to start off the whole process of using the platform. So as I mentioned, the dashboard of reports, there are numerous reports that we've built and that are available. I'd just like to share some of them that you get at least a flavor of what's possible with this dashboard. What you see on the left-hand side is an example. So the line chart, this is just showing the evolution through time of the numbers of persons who are vaccinated. The blue line is showing those having received their first dose of vaccine. The green line showing those who have completed doses 1 and dose 2. If you move to the central picture, this is showing at an aggregated level, really just high level the numbers of persons who have completed dose 1 or the dose 1 and dose 2 vaccination. And then on the right-hand side, you see another example of a report. This is really a view into the compliance with which the second dose of vaccine is being administered in respect to the preferred dosing window. So each vaccine has their own specific dosing window. So by that, I mean the number of days between dose 1 and dose 2. So the red bar in this case showing the dose 2 administration outside of window, the green bar showing those that have been administered within the dosing window that's preferred. So all of these data can be exported from the dashboard, be it in Excel, CSV file format. So it makes it very easy if you want to do further analysis or just basically pull these data into another system that can be readily achieved. So what about the user interface that's running on the tablet? So if you remember the picture of the field nurse using the tablet, we feel this is a very user-friendly interface. As I mentioned, there's a record prepared for each person who is being vaccinated. You'll see here, this is a representation of that record. So you get the photograph, the passport photograph of the individual to be vaccinated, their specific ID that you've maybe read in by scanning the barcode or manually entered. Then there's an indication. In this case, we used iris scanning to identify this person, and you see that indicated. And we also proceed to capture a minimum of demographic data, so the gender, year of birth, the person's phone number, their place of residence. And if the keyboard would disappear, you'd see there's also a further field which captures their preferred language. And we use this to trigger the mobile messages in the correct language to the individual that you are wanting to inform. So what you see on the right-hand side, this is actually a picture of my own mobile phone. So basically, as long as you have a connected device, you can tap into this dashboard of reports. This is an example, another example of a geographical map showing different locations of vaccination and the numbers at the health centers that are being achieved. So basically, you can take your dashboard with you, and it makes this readily accessible to those who need to know. So the last component of the platform being the mobile messages, as I mentioned, we're sending out appointment recall messages. We're doing that in the local languages, and that can take the form of either written messages, be it WhatsApp or SMS text messages, or pre-recorded voice messages. And this last piece is quite important in certain populations where you may have literacy issues. So you can play with how you want to set up the messaging. You can decide, for example, to send a welcome message while the person is still with the vaccination team. And that allows you then to check whether the person's telephone number that they've given, if it's activated, whether it's correct and you've accurately captured this. We can send the appointment reminders, as I just mentioned, motivational messages, other just practical tips or health informations, or even a reminder if you notice that the person has missed their visit from the reports that we're generating, you can tell us. So there are ways to trigger, ways to encourage them to come back to the clinic. And last but not least, the ad hoc messaging that I mentioned. So you may not have planned for some messages at the outset of your campaign, but like the example I gave of the closure times of the health centers in Rwanda, you may need to adapt the messages that you want to send as your campaign for vaccination progresses. So when you pull all of these components together, how does that look like for a routine vaccination process on the ground? So let me walk you through how a dose 1 visit, for example, looks like. So someone from your community will show up at your vaccination center or your vaccination post. You're going to capture those minimum demographics. You'll give the unique identification to them, be it through iris scanning or your other means that you've decided on. And then I think a very nice application of the barcode reading from our platform is the nurse or the healthcare provider can actually scan the vaccine vial. So the barcode that's on the vaccine vial gets read into the platform. So basically you're linking at that point the exact vaccine that you're giving to the individual person that you are about to vaccinate. you will then see that the person starts to receive their mobile messages, and hopefully they come back then, as this should encourage them for their dose 2 visit. So again, here, much fewer steps in the process. Person gets their iris scanning performed. They have their eligibility check for giving the dose vaccination of the second dose. You scan the barcode again, and the process is done. And again, the dashboard of reports is running across all of this. So let me conclude by just presenting the characteristics of the platform as we see it. The platform is not tied to a J&J vaccine only. This can support multiple vaccines all in the same campaign. We've built in vaccine consistency checks to make sure that the vaccine used at dose 1 is the same as used at dose 2 visits. We have checks for correct administration within the dosing window, as I mentioned. We're using iris scanning as a unique identification starting point. We feel that the platform has powerful reporting capabilities. As long as you have a connected device, you can hook into this. We have the capability to send pre-recorded or ad hoc mobile messages. Again, the train-the-trainer approach has proved very scalable in Rwanda. We find the interface is intuitive and very mobile, and we have the possibility to integrate the platform into other pre-existing healthcare systems. We feel we've proven the scale-up capabilities of the platform with the large-scale campaign in Rwanda, and we see very effective coverage rates for 2-dose vaccination campaign that's running there. And all in all, we feel that this has a broad public health applicability. We started this effort in Ebola. We've customized it now for COVID, but actually the platform is totally agnostic of the disease indication. We think that this can be used for any kind of large-scale vaccination campaign that you want to run using a multi-dose vaccine regimen or even a single-dose regimen. And with that, I'll stop my presentation, and I think we're happy to take questions.
Thank you very much for your presentation, Paula. So it's now time for the Q&A. You can stop the screen sharing, and we'll start with asking our judges if they have any questions. First, I'd like to give the opportunity to Patrick Oseve. Since you couldn't ask a question previously, would you like to ask a question?
Yes, thank you very much, Paula, for an excellent presentation. I have 2 questions. The first one is that you say that the platform can be used to address rumors and to send accurate information. How do you deal with people who are not literate? How do you communicate the information? The second one, can you just say more about how the reminder system works? And how was that used for the Ebola outbreak?
Yes, thank you for the questions, Patrick. So basically, in terms of the rumor, how that is addressed, so generally how we've seen this is in complement to community engagement efforts. And we know from the community liaisons who are operating in the community what the questions and the rumors are that are being picked up on. So basically, we have that hooked up to our communications team, and we can develop a set of information that can then be used to address that, and we're sending that out. So in terms of how you do that for areas where there are literacy problems, there, I would say you wouldn't send necessarily that in a text format, but then you would use the capability of the pre-recorded voice messages. So you would deliver that information as a spoken message, sending it again to the mobile message, to the mobile phone of the individuals that you're targeting, and in that way you would get around the problems that maybe you have with literacy. Yeah. And sorry, I've lost your second question, Patrick.
How does the reminder work? Yes.
So the reminder works because basically the system keeps track of when people are showing up for their visits, and you can actually provide a listing of the persons that you're expecting in a certain time frame. And if the team sees that, let's say that they have not fulfilled or they're defaulting on those visits, then indeed the system can be triggered to send reminder messages to tell them when they could come back. And either you use that as a standalone, or you use that in a combination with your community liaisons. You provide the list to them to say these people were missing, they haven't showed up at their clinic appointments, and they then maybe do door-to-door efforts as well. So I would say that the collective of that is the way that you try to entice people, encourage them to come back to complete their regimens.
So my last question, how could this be used if, because the population that we've covered so far is 200,000 1,000 people. If you are to do 4 million people in Rwanda, how would this work?
Yeah, I think that's a question of, and maybe Roman, you want to speak to the technicalities of it, but my assumption is that this is all about the dimensioning of the servers and really the capability of dealing with that scale of data, Patrick. But certainly I think that's how you would approach making this more accessible to a larger population.
Yeah, the platform is built for scale, Patrick. So we have 200,000 participants, but that's actually 400,000 touch points in Rwanda, because we have a first and a second dose. We need to scale just by providing additional tablets and infrastructure for the local teams that all connect to a central location and central server. It's all about dimensioning the central server to accommodate larger numbers.
Thank you.
And maybe I can add to the reminder messages. So the standard reminder messages can be configured in the system automatically. So there's no interaction necessary afterwards. And it could support vaccines with different dosing windows between dose 1 and dose 2. So the system would find out from the vaccine when the reminder needs to be sent to the participant for the next dose, whether it's 2 weeks, 4 weeks, or 6 weeks, depending on the vaccine that was chosen.
Thank you very much. Thank you.
Sarah, next question, Andrew.
Yes, thank you very much for your presentation. I really enjoyed it. Just really quickly, I was wondering if you could comment on the privacy, security, and data protection standards that are in place for this, especially given the use of biometric data linked to vaccine records.
Okay, I'll take that one. So all data, all data that we store is encrypted, Andrew, in storage as well as in transit. So there's no data residing on the tablet. So all the information is transmitted to a central location and central server. And that server can be located at a place of choice for the implementers. So sometimes we see that countries prefer to have that data stored within country. So we use data centers in the country, or it can be stored in the cloud when we are addressing global campaigns as well. But all the data is encrypted in rest and in transit.
Thank you. Thanks a lot for that answer. Next question, Patrick Silborn, would you like to go ahead?
Sure, thank you so much. Excellent presentation. Really love the simplicity of the solution as well. Could you say a few words about the data and the dashboard and how the dashboard can help facilitate decision making, and if it does, based on your experience? And the second thing, linked to data is how do you link to existing platforms, whether it's so the HS2 or others? Like how interoperable is the system, so to speak? And the second question is more about the tech solution, the tablet and the iris scanner. How robust are they to be able to work in very rural, remote settings? Have you had any issues with sort of technology failing? Thank you.
Yeah, maybe I can take your last question first, basically because it's the quickest to remember. No, the experience with the equipment, I think most of the projects or the implementations that we've done so far we always foresee a certain reserve of equipment. So indeed, we have a mitigation already in place if there is something wrong with the equipment, and the selection of the let's say the equipments are generally ruggedized, so that in terms of being dust-proof, waterproof, we have already taken that into consideration with the selection of the tablets that's being used. Then you had a question with, yeah, go ahead,
the tablets that we are using are standard tablets, so they're available.
Yes.
They're not very specific developed devices. They're just standard Android tablets that can be used.
Great. The first question I had was more on the dashboard and how the data is being used for decision making, how you integrate with other systems.
Yes, I think with regards to the decision making, what we've seen is because you can actually follow the throughput of your health down to a health center level, you can actually link that to your stock and your staffing. We've seen that in Rwanda that let's say that they use the throughput that they're seeing on a daily basis to make projections of how things are going to be running, and they know basically the uptake of the amount of vaccine that they have been processing on a daily basis at all of the individual health centers, so they can tailor, let's say, their supplies around what they're seeing in the data from the reports that they're drawing from the dashboard. So indeed, this does allow for decision taking. Also, what they've seen is in terms of staffing, if there's not large uptakes of vaccine in certain health centers, which they can also follow in the reports, then they may decide to shut certain health centers and reallocate their resources to areas where there's a much quicker uptake and where they need to cover, let's say, a larger population that's showing up at those centers. So that's the kind of decision taking that we're seeing happening on the basis of the dashboard reports.
And I think in terms of the integration, Patrick, the question that you asked, so that we have no direct integration at this point in time with any of the system, but it's easy to export the data that we have available. And we would be able to integrate that with any system based on a unique identification that is used by another system. So we can export and import data from the system into any other system. If a more tightly integration would be required, that's also something that we can explore.
Thanks a lot for answering those questions. Next, I think, Mark, you had a question?
Sure, I think it was partially answered there. So yeah, I'm really intrigued and interested more about this interoperable capacity. Yeah, it's easy to express that, yeah, the data could be exported and using the unique identifiers. Of course, in fact, I mean, most countries in the region aren't starting from scratch. There are existing platforms being used in some capacity for the COVID-19 delivery of vaccines and the distribution, et cetera. So specifically, where have you been able to deploy and use this for COVID? And then what has been that engagement for working with other platforms and systems? Maybe you could describe how you've gone about this in one example, or even from the Ebola examples before, how you have linked and integrated, if not interoperated with an AVI or some other way. Thanks.
Mm-hmm.
Yeah,
I think
maybe. Sorry, go ahead, Roman.
Go ahead,
That's
Paul.
fine.
No, go ahead. Go ahead.
No, I was just about to say how we've adapted the platform for COVID. Obviously, with Ebola, we were only dealing with one vaccine, so we have now foreseen the capability to support multiple vaccines at the same time into the platform. Also, being able to run the program across various geographies. So also the dashboard of reports is reflecting that. There are reports that show actually the data that are being pulled across whatever geography that's being used to deploy the platform. So there has been a fully customized step or configuration of the platform already put into place for COVID, Mark. Yeah.
Yeah. And I think in terms of the integration, Mark, for Ebola, one of the reasons to implement that additional field where we can enter or scan a barcode or a unique identifier is that is the one that can be used to scan identifiers that are being used by other systems to ensure that data that we export can be connected or integrated based on those identifiers with the existing systems.
Thanks a lot. I think we still have time for another question. So Julie, please go ahead.
Yes, thank you. And thank you for the presentation. Have you seen any hesitancy in the populations for the Ebola vaccine with regards to having a picture taken and using the iris scanner by patients coming to get the vaccine? And is there an alternative to the picture being taken in the iris scanner to collect the necessary information on that patient, enough to track their follow-up dose, for example?
It's an interesting question, Julia, one we often get. I think everyone seems to have a certain idea or perception around the technology and how people will react to that. But actually, we've seen quite to the contrary of what maybe people think. And there's been a large embracing of the technologies. We've done some formal studies actually around that more recently with some collaboration work that we've done in DRC. And there we've seen in the population of healthcare workers that we were deploying the platform for, that we saw levels of acceptance of the technology, be it for mobile messaging, be it for having a photograph taken, or even iris scanning. We did a formal acceptance study, and that was around 99% of those individuals accepted the use of the platform. In the cases where there was no acceptance, I would say that the reasons for that maybe because people had an eye problem or something like that. And in those cases, the workaround indeed is what we have already built into the platform, the alternative entry points that I mentioned. So even if you think away the iris scanning, you can still start with the reading in of be it a barcode or the entry of a specific participant ID, whatever has been agreed with the implementing party that you want to use for your campaign. So yes, we are using our routine of iris scanning as a potential starting point for identification, but actually you can do all of the efforts in the platform like I just showed without that. You can start, as I mentioned, with reading a campaign card, or even just simply entering an identifier into the platform, and then you can do the further steps of the dashboard and the mobile messages, etc., etc.
Yeah, and I think on top of the formal study that you did, Paula, to check the acceptance of the iris scanning, we see similar high acceptance, Julie, in the campaign of 200,000 participants in Rwanda. So it's also around 99 point something percent of people that accept the iris scanning and the photograph taken.
Thanks a lot for answering this question. So that's the end for our Q&A session here. And now next team to go is Reach 52. So team Reach 52, please go ahead. You can share your screen and we'll start the timer when you're ready to go.
Great. I'm off mute. Can you hear me and see my screen?
Yes, we can.
Excellent. Just setting a timer for myself. So yeah, good morning, good evening, good afternoon, everybody. I'm Edward Booty, and I'm founder and now CEO of Reach 52. We're a Singapore headquartered health tech social enterprise focusing on last mile health access. So yeah, 3 parts to the presentation today. Firstly, going to tell you a bit about our core model and how everything works at the moment. Secondly, what we're planning for COVID vaccination and some of the enhancements to the solution. And thirdly, really about how we scale, which I think is probably the most exciting part, to be honest, given we are very much a multi-country solution. And yeah, thank you for the previous presenters. Thanks for the invite. And yeah, hope you're all well and really enjoyed the previous presentations as well. Excuse me. So yeah, firstly, our name. We are Reach 52. Our name comes from the fact that 52% of the world, or 3.7 billion people, cannot access healthcare, according to the WHO in 2018. And everything that we do is trying to connect them to essential products and health services. And how that works, similar in a way to the previous presentations. We go to rural communities and we build a network of agents and community health workers. So it's a blend of micro entrepreneurs and community health workers, normally 1 to 2 per village. We often have them hired by partners such as NGOs or direct partnerships with government as well, sort of growing through trusted established networks on the ground to establish this field force. We then equip them with our platform that I'll come on to later, the tech. We train them, we pay them. They firstly normally go door to door and collect data on healthcare needs. So height, age, weight, current diseases and so on, and really market the service that we're bringing to the community. And then based on having the better trained health workers and, these micro entrepreneurs, we run a range of data-driven and targeted health awareness events, screening campaigns, bringing doctors to the communities, to provide access to medical advice, as well as buying and distributing affordable or discounted medicines, consumer health and insurance plans. So yeah, we collect the data, build the field force, use that data to do sort of village level targeted programs, as well as very precision household interventions, which we have been doing for COVID-19 as well. But then, yeah, we also do give access to discounted private sector products to supplement the public sector health system. All of this is based on a fully offline Android app. It does not need the internet at all. We're pretty small. We have about 10 or 15 developers full time now, but this really does provide, you know, the end-to-end primary health journey, I guess, from the data collection, run events, do these targeted campaigns, basic medical records with vitals, order medicine, deliver medicine, scan prescriptions. And yeah, I'll talk about our numbers later so far, but yeah, it really is a sort of basic, you know, offline first, Android platform to support all of these activities used by this network of micro entrepreneurs and the community health workers themselves. Worth noting as well, it also runs on Android version 4, which is from 2013, I think, and about as old as you can go on Android now. So yeah, everything we do is painfully built for no internet and the cheapest phones money can buy, which has been really important for our scalability as well. Linking some of the previous points on data, absolutely, we collect data up front. Every activity we do is driven by that data. And there's a number of web dashboards already. So there's one for the pharmacies, if we're selling medicine, view the orders, dispense the medicine, pack it per patient, per village, ship it to us. There's one for the health centres, view the dashboards, cut your data by village, etc. There's one for our insurance partners and so on. So we have built the web dashboards for these different stakeholders, you know, everything from product distribution on the private sector right through to the government has a view of that data and can interact, you know, with the Android app and thus the communities through that. And yeah, we're very proudly a startup, you know, can't compete with some of the great names on this call. So I feel a bit like the small guy in the room, if you know what I mean. But yeah, we support about 250,000 people a month access healthcare. There's about 5 million people in the catchment areas that we serve. Worth flagging now, you have no idea which countries we work in, so apologies for not mentioning that. But yeah, we're live in Philippines, Cambodia and India. We've just opened our office in Indonesia as well, and I'll come on to that a bit later. So yeah, 250,000 people within the agreed catchment areas that we serve, about 5 million people in scope, about 3,500 people in our field force, but that's growing to about 10,000 at the moment. 20 big global partners supporting us, and we distribute about 7,500 medicines, insurance plans and consumer health products at the moment. So yeah, 4 countries, 500 communities, and yeah, growing quite fast as well. Pleasure to see Johnson & Johnson present. Outside of this call, they're also our biggest partner, which is fantastic. So yeah, we do a lot of work with big pharmaceutical companies who often fund our services, you know, helping us reach more people, funding screening campaigns, and really, achieving their social impact goals effectively. And J&J is probably our biggest partner. We've also worked with Gilead and big distributors and Novartis, as well as big insurers and so on, to sort of fund our outreach and offer, these discounted medicines. We have done a fair bit of cold chain as well, not ultra cold chain, but we do work with insulin and very affordable insulin, sort of 70, 80% below market rate. We have done vaccination campaigns before as well, and very good tie-ups with Zuellig Pharma and DKSH in the region, given we do a lot of community-based ordering, but the dispensing or the dispatching of medicines is done in central locations. So good touch with the distributors as well. And then beyond that, we have also done projects with UNICEF and UNCDF and various foundations and so on. And also, as mentioned, proudly a startup, so we've been part of Google and Facebook's accelerator, and really just sort of tried to bring some of this digital innovation, data-centric or personalized type service delivery models to the public health space. And to some of the questions earlier, even, when we were part of Facebook's accelerator, we did build the engagement module, which was exactly, we collect the data, let's build programs for, people over 50 with diabetes, with risk factors A, B, C that haven't had medicine, and really using that data to build your cohort and then build the program, cut through the data, push out the program in a sort of more targeted and personalized way. And that could be, signing people up for a diabetes event, or distributing a medicine, or, pushing out a vaccine as well. To jump to the solution, I guess we're not planning to do too much more than we already are doing. It's just sort of enhancing it and scaling it, to be honest. So we've got a fully offline functional app for community health workers and micro entrepreneurs and service providers, the dashboards that I mentioned earlier. We want to build the vaccine tracking and monitoring functionality in that. We've already done that, similar to, or actually done sort of prototypes of it. We're just finishing it off now. Inputting the first dosage, saying which vaccine people got, and so on and so forth, tracking that key vital data, but really building it for low spec offline devices. And then linking to that, we've already done a huge amount with Facebook, as mentioned, and Facebook Messenger and WhatsApp, which are all integrated to our system for the patient touch points. So and we've done a lot with SMS as well for various public health campaigns. That's again integrated. So as we're distributing the vaccine, signing people up, getting the data, we can do it in a more targeted way, i.e. if we wanted to target people above 60 or whatever, we already have that data and can build those programs. And then from a patient or a resident point of view, have the automated SMS gateway, raising awareness firstly, social media gateway, exactly the same. And then also giving them a code and follow-on information as required. We've also done a lot around adverse event reporting, given we are a rural pharmaceutical distribution partner. So adverse event reporting is already sort of built in as well and can be used as a channel to do that. A rough patient journey, or not patient, but journey in general, or pathway, perhaps I should say. Patient would be registered in our app. The first dose would be digitally recorded. The patient receives the QR or alphanumeric code after the first dose, which links to their personal record. Provider updates the app, our app, which can obviously link to stock control and so on, that we already do a lot of already. Patient receives reminder for second dose via SMS or via instant messenger. And then when they come back in, the code or QR code can be scanned by that health worker. So I wouldn't say what we're doing is rocket science, to be honest. But again, a lot of what we're really planning is how to scale this up, which I'll come on to shortly. And then only other point as well is just by having this network of women and micro entrepreneurs, definitely looking at the online and offline vaccine awareness already. The biggest program we've done historically is ironically with Johnson & Johnson. We built COVID-19 chatbots and trained 5,000 to 8,000 health workers to do COVID-19 awareness and prevention type stuff. So definitely planning smaller events, door-to-door campaigns, SMS to raise awareness and increase acceptancy. And then on the right, as already mentioned, we do online and offline adverse event reporting already. That could be through SMS, instant messenger, or the tech itself, obviously via the field force that we've built. A couple of screenshots, but again, we're just sort of enhancing our existing product. Just track the dose, add the dose, issue QR code, register the patient, dashboards for the health centres and so on, and obviously more regional or subnational governments as required. Patient tech solution or resident or patient tech solution, issue the SMS, get the code, get the QR code as well via a sort of instant messenger of your choosing. Value proposition for us is very much, we wanted to connect the patients, the frontline health workers and the health systems, increasing vaccine access, increasing the patient engagement, and really managing that logistics coordination between the frontline and, the health systems and the health providers, similar to a sort of hub and spoke model, like mentioned earlier, like we're doing already and have done for previous vaccination campaigns. And then, yeah, going into the last part, and yeah, I've got 3 minutes left, so I'll perhaps speed up a bit, but hope this is summarized nicely, and sorry if not, if going too fast. But yeah, as mentioned, we've grown so far. We're only 4 years old, right? Less than that in terms of actual implementation. 3 years old, to be honest, since we launched in the Philippines. And yeah, we work with partners on the ground. So we work with well-embedded NGOs that have good community trust. We offer them our products like discounted medicines, tech, and often funding to grow. They help us recruit the agents and train the agents in their catchment area. Those agents, whether it be independent or community health workers, sign up their residents and coordinate these local health services. And then we obviously generate revenue, which is a mixture of grants, B2B, and obviously as we are selling these discounted medicines and the micro-entrepreneurship model, small commissions, so sort of 3 revenue channels that is then split with the NGOs. So yeah, sort of as we grew, we've really tried to embrace this more. So given we spent way over $1 million on our tech now, so we sort of put the Reach 52 model and the tech on various NGO tendering websites is how we scale. So, where NGOs would go to look for funding or support, like ngofunds.org and other similar sites. And we just said, look, you can have our tech, we'll provide what funding we can. And, here is an offline first platform that you can use. We've had about 200 partners across 26 countries apply for that in the past 6 weeks. So yeah, it's pretty exciting actually. We've just had one of the largest pharma companies in the world give us $250,000 to do that in Kenya with 10 NGOs, which is pretty cool. We've got 35 applications in Uganda, 10 in Indonesia, which is our biggest priority market where we've set up an office, if you will, one of which is the largest NGO in the country. So I guess, yeah, we're really trying to take a step back from that service delivery, build the tech, and then really empower civil society and people on the ground to help us scale. 1 minute left. So yeah, we're really passionate about making it sustainable. We're going to open source it, to be honest. So everything we build will be free, community-based software. We've already got to do that for a program with UNICEF. So yeah, we're really passionate about that and don't want proprietary software ourselves. Big part of the judging criteria is impact. So I just thought I'd throw this in. We are very proudly a social enterprise. 15 seconds left, I can hear. So yeah, we do have external social impact assessments, social impact audits, and for every $1 we're making, we're saving $2.10 in healthcare costs. So that's discounted medicines, that's saving cost and time of travel, and yeah, very passionate about that, and do have some externally validated impact assessment as well. We're about 50 people in the office now. I lead the team, strong top team delivering this, and yeah, thank you for listening, and sorry for being 10 seconds over.
Thanks a lot for your presentation, Ed, and for finishing spot on time. So it's now time for the Q&A session with the judges. You can start with the screen sharing, Ed, if you want. Yep. And we'll start asking questions to our judges. So who would like to start? Patrick or Serve, maybe, would you like to start?
Yes, thank you very much for a very good presentation. I have 2 questions. You indicated that you have many big pharma as your supporters and members. What exactly do you do, for example, Johnson & Johnson?
Yeah, it's funny to have Johnson & Johnson as a competitor for the day, but they're also our best friends. So yeah, we're enemies for the day, but best friends in general. So yeah, we do a whole range of things for pharma companies. With Johnson & Johnson specifically, we are training 10,000 barangay health workers in the Philippines in 3 disease modules. So diabetes, hypertension, and maternal health, which involves offline training, online training using our tech. They then do 2 months of door-to-door data collection on risk factors for diabetes, and then they do targeted screening based on that data. 2 months later, hypertension module, offline, online training, 2 months of risk factor collection, 2 months of screening, and so on and so forth. With other people though, with Gilead, we've been doing more around hepatitis B and HIV, health worker education, screening, access to treatments. People like Novartis, it's been more around NCDs. So yeah, the programs do massively vary. Worth noting as well, our view on social enterprise is that we've built a hybrid structure. So in countries, we have an NGO that does social projects with government, receives grants and stuff, and a business which sells discounted medicines and so on. So yeah, the pharma can sort of interact with us in two ways. Sometimes it is, like grant-based sponsoring programs, and sometimes it's really looking to create a sort of new business model through affordable treatments. And then we manage the conflicts of interest by running these hybrid, legal entities basically in two separate teams, I guess.
Thank you. And what do you do in India and Kenya?
Yeah, all much of the same, to be honest. Our model is fixed. Worth noting on the, I guess, yeah, so what we do in India our model is fixed. Yeah, we train independent micro entrepreneurs and community health workers. They collect data on healthcare needs. Based on that data, we run more precision local primary health services, and then they can also give access to affordable, discounted private sector products. And it's just really, we tend to only work, we've never worked in cities, it's worth noting. So we always work in communities at least 1 hour away from a pharmacy and clinic, normally 4 to 5 hours away, 5 to 8 hours away from a hospital or secondary care facility. So yeah, it's always really the same of pushing out these more, disconnected rural access to healthcare, access to primary health programs in sort of more rural agricultural farming, fishing type villages, which I should have mentioned earlier. Only at the point though, yeah, just because we are in so many countries, it's just worth flagging that the tech has been built for that. So all the back-end database, if you're in Kenya, data goes to Kenyan servers. If you're in Indonesia, data goes to Indonesian servers, and translation is like user configured. So if we want to put it in Bahasa today, we can do it in about 2 days. So it's not actually coding to change language as well. So we've, as I say, really tried to take a tech-driven approach to empowering civil society in these countries to scale, if that makes sense.
Can you shed some light, my last question, some light on how you could do this for COVID?
Yeah. Well, again, linking back to J&J, we have already done a lot of awareness and so on about COVID, because we have a lot of data, right? So we knew who the diabetics were and who the older people were. So as, awareness and prevention and, hand washing and all the other campaigns were coming out, well, a year ago now, we were doing more precision interventions for that. So cut through the data, here's the most at risk cohort, go and do ABC to them, deliver this leaflet or whatever it might be. So I guess we've already been taking our approach and applying it to that. And then in the context of COVID, more of the same, targeted and more precision vaccine delivery. And then as mentioned, really just looking to enhance our tech to do the tracking of vaccines, specifically the dose vials and the patients and so on, SMS and QR codes for the patients to get their follow-up and receive information, and just, basically take our standard journey and use it for vaccine administration and patient engagement or community engagement, really.
Thank you.
Thank you as well
for answering these questions. And next, Andrew, you have a question?
Thanks very much. It's a very interesting model. I really appreciate your presentation. I had 2 questions. One is that you emphasize the role of rural NGOs in your work, and I think it's one of the strongest parts of what you're doing. I'm wondering how you would have to change your model, if at all, if you were working with government units as opposed to NGOs. And I guess the second is around data ownership. So especially as you kind of scale out across all of the areas that you're working, did the rights to the data remain with the implementing partner, or is that centralized in some way through Reach 52?
Yeah, lovely questions. Obviously huge areas, and I'm going to have to whistle stop it. So thanks for the NGO thing. It's something we stumbled upon. Philippines, we implemented ourselves. We then were launching in India, and we got blocked, due to COVID, couldn't travel and stuff. So we said, hey, why don't we get NGOs to implement our model for us? It's faster, cheaper, quicker than us doing it ourselves. Why try and rebuild that trust network in these communities when there's people that do it better than us? So yeah, it's sort of been an organic learning as a result of COVID that's completely changed the way we scale and made it like 10 times faster, basically. However, governments are fully involved in all programs. We do have formal MOUs, either directly or through the NGO, for every single one of our programs. When doing screening campaigns with Johnson & Johnson or Gilead, we are training government health workers. We have never worked with a private sector doctor. We train government health workers to do these primary health services and empower them through a sort of blended public-private partnership model. So I guess it doesn't change, no, because I guess if anything, we look to piggyback on the NGO's trust, but it's always blended with the government resources available that we look to upskill and empower and, you know, just generally support. And yeah, that's the same for every country that we work in and will continue to be so. Data ownership, yeah, huge question. Obviously, yeah, data residency and stuff is held within the system. Again, when we were part of Facebook's accelerator, I was obsessed about legitimate consent, which is not just getting people to tick a box, you know, to say, give you consent. But actually we did a lot of animated videos, cartoon strips and so on to really help people understand what it means and what their data rights are. And then they can tick the box and then their data is encrypted, blah, 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 in country. My view is that the patient owns the data. So if the patient wants to be forgotten, wants to do stuff with their data, that is their prerogative. And then the legal relationship between us and the NGOs varies slightly by country, just based on local ownership rules, data processor data, so on and so forth. But yeah, we are the sort of data controller. They are the data processor generally. So we both have full access to it, as does the government, for what it's worth. But I guess, yeah, it's sort of more like a tripartite arrangement where we're clearly the tech vendor. They are clearly managing the touch point with patients. Therefore, we both have legitimate interests, as does the government. But we're also trying to weave in that element of patient consent and patient control as well, which has been a big part of what we've been focusing on, to not sort of potentially abuse, you know, people with lower digital literacy that might not know their rights, you know. It's also just, yeah, just the only other point I would on that, we also have what we call incremental consent. That's something we built, it's pretty nice. So like, let's just say I'm the agent, you've come to me and you want to buy insurance or something, then I would have to send your data to the insurance company, right? So at the point of that transaction, you can authorize us to transfer your name, address, you know, listed beneficiary to insurance X. So we've also tried to bake in iterative sort of points of consent along the journey to allow us to do different data transferring as required, which is something, yeah, that was quite complex, but also needed. Sorry, long answer.
No problem. Thanks a lot for answering that. Patrick Silborn, you have a question?
Yes, thanks, Ed. Excellent presentation. I guess this question is very much linked to Andrew's questions, as well as my hand was going up and down. So I kind of felt that much of it was already answered, but I felt that you know, the model is very NGO dependent in a sense. And my question was, how do you see that there's opportunity to scale beyond NGOs? That's, I guess, number one. And how do you see sort of governments playing a sort of bigger role, maybe not only as partners, but actually driving this from your perspective? Because the tech side of it is really interesting. Yeah, I guess that's my main question. Thanks, Ed.
Yeah. So I was writing down these questions so I don't forget them. So yeah, beyond NGOs, I guess, well, yeah, if you think about it from the honest answer is, yeah, we're like a 4-year-old health tech startup that's like doing some interesting stuff, right? So we did try and go to national departments of health to say, we've got this cool model, we've never done it before. And they're just like, no, we can't like exactly sign a nationwide agreement with you, right? So we've had to sort of, yeah, start small and build ground up, which I think is, yeah, one of our strengths, of course, but we haven't had that ability yet, I guess, because we have, you know, come from nothing 4 years ago. The dependent on NGOs is true, but, you know, we are working with some really big established ones, often getting USAID funding or other big grants. So I guess part of it's the pre-selection process and working with the good ones. But absolutely, you've hit a really interesting point. We do have a current project with UNICEF Innovation, which is looking at using village stores as access points for health. We're just launching that in the Philippines at the moment. So using smaller retail outlets as an alternative to NGOs. We're also speaking to some of the biggest microfinance institutions in India. We have a pretty big grant out with them at the moment, looking to leverage micro entrepreneurial networks as well. So we're definitely looking to grow beyond NGOs, but I guess just given we are health at the end of the day and we're going into new markets, it made a lot more sense to go with NGOs first that do health, versus, going with an MFI that doesn't, what I mean? They don't know the market. So it's just a better starting point. And government roles, it's sort of the same point. It was always supportive, but we're not big enough to justify a nationwide partnership, I guess. But now we are getting scale, definitely in the Philippines and India. We are in provincial level discussions. We have just signed an MOU with a large province. So we work at municipality level in the Philippines. Above that's the province, and then goes up to national. We are now signing provincial level agreements covering 45 municipalities. So we are working up the ladder, if you will, of government engagement. And similar in India, state of Karnataka partnership, directly with the minister, directly with the entire state, covering 44 million people. But that's only really been possible from some of the smaller scale implementations that show we can do what we say we can do, sort of thing. But essential to get scale, and it's just been part of our journey, I guess, and has to come sequentially.
Thanks a lot for answering that question. And next, maybe Julie, do you have a question on your side?
My question was about the data as well. So Andrew asked a very good question, very good presentation, Ed. Very much enjoyed it. I guess my question, that would remain is how would you see kind of the development of a solution, if you will, if selected, this evening to receive some of the funding? How would you use that? What would you kind of focus on? Would it be a specific country or something like that? Just to get your thoughts on that. Be very
No, I was a bit conscious that would come up. So we were going to put in use of funds type slides. I mean, the end of the day is that we've already got a reasonably large implementation network. We have 200 NGOs that want to implement our model. We can cover, and the other thing I was thinking about quite a lot is the COVID-19 pandemic has shone the light on how, how weak health systems are and how they need to be strengthened for all diseases, not just COVID-19. It's everything from diabetes to just everything, right? Needs to have a strong, resilient health system. So I think what our plan is to build the COVID-19, as I say, vaccine tracking module, which we're already doing anyway, because we think it's the right thing to do, and then integrate SMS and instant messenger outbound comms for the residents themselves, which we already do for other programs. So it's just configuration. So I guess it's just making sure, as we can buy medicines now or get normal vaccines now, we're just making sure the tech is configured for that. And then beyond that, we just want to scale faster. So we'll push it out over our existing network, over the, soon to be 10,000 health workers that we cover. And then, we're just going to open source the lot and support other NGOs use it in their countries. And just, for us, I've always said we shouldn't look at the right country, we should look for the right partners. So we're really just looking to tie up with the large at scale NGOs who can really amplify what we've done. And to some extent, we're reasonably country agnostic. But that said, the furthest forward partners there, it is the biggest NGO in Indonesia that we're speaking to very seriously, contract sort of speaking to, and a couple of very large ones in India and a couple of very large ones in Kenya as well. So I guess they're naturally our 3 countries of focus. But as I say, if we build the tech, we want people to use it and we don't want to charge people for it. And that's the sort of intervention we're looking to make, because that's what we feel we're sort of good at, if you know what I mean. I don't know if that answers the question. It's not super specific, but that's what we're thinking.
Thanks a lot for answering that question. So that's the end of this Q&A session. So now we have the 4th and last team to go, Simprints. So when you're ready, you can start sharing your screen and go ahead. We'll start the timer.
Hi, everyone. Can you see my screen well?
Yes, we can see your screen and we can hear you loud and clear.
Perfect. right. Hi, everyone. First of all, apologies if I feel a little bit sleepy. It's about 3 a.m. here, so it's 3:30 a.m. So apologize if I sound a little bit sleepy this morning. I'm Alexandra Grigore, and I'm the Chief Product Officer of Simprints. I'm here with my colleague Nile, our Country Director of Bangladesh. Simprints is a non-profit technology company spun out of the University of Cambridge with a mission to radically increase transparency and effectiveness in the fields of global health and development. We work with partners all over the world to make sure that every vaccine, every dollar, every public good gets to the people who need them most. So the challenge we're working on is straightforward but significant. Getting COVID-19 vaccines equitable to the right patients in many low and middle income countries is going to be a huge challenge for delivery and tracking. Today, health systems struggle to consistently and accurately identify patients, particularly their poorest patients. So according to the World Bank, over 1 billion people, largely in low and middle income countries, lack any formal identification, things like birth certificates, national insurance, or national health records. This makes it very hard for us to accurately track and measure who has been reached with a health intervention and who potentially has been missed. Solving the challenge in the high-pressure environment of COVID vaccine delivery is going to be even harder. In particular, there are two issues we need to address. The first question is, do COVID-19 vaccines doses go to the right people? With nearly 1 in 7 people on the planet lacking any ID, this makes it really hard for ministries of health and their partners to track and prove that doses are getting to the most vulnerable populations. This vaccine verification challenge makes it much harder to ensure that there is neither accidental nor potential deliberate leakage within the system, a huge issue for what is going to be a highly precious public health commodity like COVID-19 vaccine. The second question, did patients receive both doses? Many of the leading contenders for the COVID-19 vaccine, such as the Oxford AstraZeneca vaccine, are multi-dose, which means that we need to be able to track if the person receiving the first dose actually comes to get the second dose. Vaccine cards have a high loss rate, up to 60% in some studies. And so without the ability to ensure and track vaccine course completion, it can be much harder to understand if we truly have immunity in key areas or target our public health response to help prevent and reduce these coverage gaps. So our idea is to provide frontline healthcare workers from governments or their NGO partners with Simprints biometric technology, such as fingerprint or face recognition, to verify that every vaccine dose has indeed been delivered to the right person, that every person has received the correct number of doses of the right vaccine at the right time. And this will help ensure that no one misses out on vaccinations, doses are not lost due to inefficiencies, wastage, or fraud, and we can do a better job of tracking and following up with patients in case of mild and adverse events, improving the quality of our public health data. Gavi and other global leaders within the sector, like the World Bank and the Center for Global Development, have already identified biometrics as a potential game changer for fighting epidemics and improving routine immunization. In this context of COVID-19 vaccine, we think the value proposition for biometrics is even stronger. We know that the initial supply of COVID-19 vaccines is going to be limited, so every dose that doesn't reach the right patient at the right time is potentially a life lost in this epidemic. We know from our deployment experience working in many countries, in many contexts, that biometric digital ID tools can help reduce fraud, increase access, and improve the quality of the public health data about who we've reached and who we've missed. So how does the underlying technology work? Simprints is a biometric plugin that integrates with existing health tools already used at scale by many ministries of health today. For example, Simprints plugs into DHIS2, a widely adopted digital software that many ministries have already declared to be their platform for delivery and verification of COVID-19 vaccine. So using the technology, a healthcare worker can capture biometrics like face or fingerprint as part of an already existing workflow. The whole process takes less than 90 seconds, about 30 seconds with face recognition and between 20 and 60, 70 seconds, maximum 90 seconds with fingerprint. The Simprints can run a matching algorithm completely offline, allowing it to work even in contexts that do not have connectivity, and quickly ensure that the right patient is connected to the right medical record. Phones holding these records can hold hundreds of thousands of data records, making sure that the technology is scalable and secure and can support the accurate distribution of COVID-19 vaccines. Simprint offers two different biometric solutions or modalities, specifically a contact-based fingerprint solution or a contactless face recognition solution. There is no universally correct or perfect biometric, so choosing the right modality depends on the country context, cultural sensitivity, accuracy required, and other considerations in program design. So by offering both, we let programs choose what's going to be best fit for their needs. For example, contactless face biometric, like you see in this photo, it's using the phone camera of health workers and allows for rapid deployment with reduced risk of transmission through physical contact. Additionally, the use of face technology is highly accurate, fully mobile, and can work in offline environments. In other contexts, due to cultural factors, not all patients might feel comfortable using face images, which is why we also provide a highly accurate fingerprint solution. Our fingerprint scanner is easy to use and maintain and is developed exclusively for scarred, worn, and sometimes damaged fingerprints common amongst low-income manual laborers or farmers. It's mobile, works fully offline, and critical for this context, has an independent battery source. The scanner is also rugged and waterproof, making it suitable for most challenging last-mile environments, as well as ergonomic and easy to use by frontline workers with feedback about the quality of the image incorporated in the design. As you see in the photos, the feedback, the LEDs light up on the scanner when the patient is placing the finger on the surface of the device, giving an indication on whether the placement is correct and the quality of the image is good, which is the most important thing when using a biometric. So as a nonprofit and ethical biometric company, Simprint is committed to the strictest privacy measures to ensure patient data stays safe. We adhere to GDPR, some of the toughest global standards when it comes to data privacy in all our programs, wherever they are in the world. We use the highest standards for data encryption, and in the architecture, program design ensure data siloing between biometric data and patient data to protect patient privacy, as well as potentially enabling anonymous testing and linking to patients without using other demographics like names or date of birth. So how do we work? Every single national deployment of COVID-19 vaccines is going to be different. So it is really important that we're tailoring the correct technical solutions, program design, and support for that context. We understand that tech can break in last mile context, so we highly recommend starting with good quality program planning to understand the specific use case and the specific needs. Then pre-deployment, where we're able to do the technical integration with the chosen digital platform used in the country context. We are already integrated actually with the majority of these platforms. We do pilots to make sure that we're testing and ironing out any challenging around behavioral design, local acceptability, other issues we might need to consider in the project design phase. And finally, we fully support across the course of scale up, ensuring that we can have impact at scale. So key to our approach is designing our programs for long-term sustainability in mind. Simprint is fit for purpose for low and middle income country contexts and has a high focus on building local capacity with our ministry partners. We've done this all over the world, for example, in our national partnerships with the Ethiopian Ministry of Health, where we support the ministry through technology capacity training, development, training of trainers, providing key materials to ensure that once the program ends, the ministry retains the ability to safely deploy biometrics without our support. The technology itself is designed to be interoperable, meaning that there is no vendor lock-in and we can be replaced by other vendors if the partner desires to do so. We integrate with the systems our partner already have in place. Excuse me. As an ethical company, we have a commitment putting privacy and data security first. We are not for profit and tailor our services for each partner, cutting out unnecessary costs in our programs, allowing transparent, clear reporting to countries as well as their donor partners. And finally, as an organization, Simprint has deployed globally and has a long track record of impact. Specifically, we deployed in 14 low and middle income countries, largely concentrated in sub-Saharan Africa and South Asia. And we had the privilege to work with a wide range of partners, including Gavi, the Vaccine Alliance on immunizations, and other programs ensuring that every vaccine, every dollar, and every public good is getting to the people who need it most. Our experience and track record enable us to provide us the capacity to scale and succeed in vaccine tracking and monitoring in low resource settings, giving COVID-19 vaccine distribution the best chance to help the most number of people and end the pandemic. Thank you very much.
Thank you very much for your presentation. Okay, so it's now time for our final Q&A session. You can stop sharing your screen if you want, and we'll go over to the judges. And I see that Mark has a question already. So Mark, you can go ahead.
Great, thank you as well for excellent presentation. And of course, all four have been just outstanding. So can you describe, have you had any experience already with implementing this for the COVID vaccination campaigns? COVID being, of course, nuanced with some of the issues we mentioned in terms of 2 doses, for example. And then in Asia Pacific region, many countries are using open source technologies. You mentioned integration with platforms like DHIS2 or ComCare, et cetera. Specifically DHIS2, could you share with me what has been some experience interoperating with that platform, perhaps the tracker module or some kind of a immunization registry? And then lastly, it would also be important to understand how the resources would be used if you are the winner. That would be interesting to know as well. Thanks.
Fantastic. Thank you so much for the questions. All right, so the first one around being already deployed. So we're actually right now in the process of implementing this. Unfortunately, because this is a public setting, I can't disclose the exact country where we will be deploying because the project hasn't been made public yet. But our team is actually flying in a few weeks' time to start the implementation. So we are not implemented yet, but we are in the process of implementing this right now. So in the next months, we will be rolling out our first COVID-19 distribution program with a Ministry of Health in an African country. So that's, apologies, I can't actually say more because it's a public setting, but I can provide this information in private. Regarding the platform and open source, yes, so we are already, as I mentioned, integrated with OpenSRP, ODK, ComCare, and so on, and DHIS2, all of these being open source platforms. With the DHIS2, we are integrated with the eTracker, so the Android-based. We are completely Android-based as a platform, so we can integrate with any Android-based platform as well. So far, the integration with DHIS2, I would say it's about 90% of the way there. We've done an integration ourselves and we tested it, and now we're actually working with the University of Oslo to include us in their next official release. So right now we have a team of engineers from the University of Oslo, which is reviewing our integration and planning on incorporating it in a release. And we will use it actually for 2 projects, one of them being in Bangladesh, which is public, and we can talk about it. It's about, it will be around immunizations, and the other one in the country that I mentioned before. So that has been our experience. The University of Oslo have been incredibly useful and collaborative. So we're hoping that in the design of the process, they will make the integration possible with any biometrics. So we have an API which we designed, and we're hoping to become a standard API. ComCare already actually implemented it in their own platform. They kind of mirroring our API, and we hope that in time we can work towards a standardized API that all these platforms are going to use and all the other biometric companies will adopt, because we have 5 years of experience with data platforms, with mobile data platforms, so we had time to optimize the integration in this space. And your third question was what we do with the funding. So we are thinking of piloting this for COVID-19 immunizations in Bangladesh. And I'm actually going to pass it on to our country director, if that's okay, Nile from Bangladesh, who can tell us about the experience and the LOI that we got from the Ministry of Bangladesh. Nile, over to you.
Thank you, Alexandra. We have already received a letter of intention from the ICT division of Bangladesh government, and they really want to deploy this technology. And with these resources, we can work with the government to do a small pilot and see how we can take it to the national scale. So we already signed a MOU with ICT division back in early 2020, and we are in touch and we're discussing about certain solutions. And in Bangladesh, we're also deploying a huge project targeting 1 million women of reproductive age, where BRAC is our leading partner. And there we have reached almost the 50% mark. And this resource will help for the COVID one, where we can use our learnings of deploying that project in rural areas with BRAC, with very low resources, very low connectivity. Thank you.
Thanks a lot for answering that question. Next, Andrew, go ahead.
Thank you. And I'd like to commend you on your really clear articulation of the privacy proposition in what you're working on. I think that was really exceptional. I guess my question is on your emphasis on local capacity building, which I think is an important aspect to what you're talking about, especially as you develop scale plans. And I'm wondering if you could say more in particular about how you would kind of focus capacity building efforts around COVID-19 in your efforts, as you go forward.
Yes, thank you for that. As I mentioned in the page, local capacity building, it's something that's incredibly important. I mean, for the success of any technology, you need to have people in the ground. And especially when you're working with the ministry, it's important to have people in the ground that can deploy the technology and can also help with troubleshooting and technical support. We are a relatively small organization based in Cambridge. We have 2 country offices in Ethiopia and Bangladesh, but in other countries, we're really relying on our partners to be able to provide that on the ground support. So what we usually do, particularly for, I will give an example, this project already in COVID-19 that we're working on. So we are going in the country usually for the rollout. Actually, we're going even in the design phase of the project. We train our partner, first of all, on the fundamentals of biometrics. I think when you're working with a technology such as biometrics, it's really, really important that everyone understands the advantages, but also the risks. So we do extensive training on the importance of collecting a good quality image, as well as on the data privacy. We're actually advising all our partners to adhere to GDPR standards. Of course, we can't enforce that, right? It wouldn't be ethical for us to enforce that. However, a lot of our partners from African countries, for example, have adopted, because our product already has consent forms embedded in the product itself and the privacy notice and so on, they decided to actually adopt the GDPR standards and accept a consent-based legal basis, which was fantastic for us to hear, because we made it so easy. So we go in the field, we provide a lot of training around the biometrics, and then we also train the technical staff on the ground, on the configuration and the support of the project. And where usually we are relying on the partners to do the integrations. So our model is, even though we have pre-made integrations with some of these major platforms, the integration code is there. However, the configuration in the form builders and the workflow and so on is done by our partners. So we don't do it, especially because we need them to have the ownership on the workflow, and we need them to be able to troubleshoot. So even if the process takes longer, sometimes few months to complete an integration, if it's not done by us, if it would be done by us, it would be really quick. But we really need to build that capacity for the partner to be able to run the integration and so on. So a lot of training, and afterwards we usually have a technical support contract that lasts for, depending on how long the project lasts and how long the client wants us to be there. To be fair, some clients never need any support, any technical support, because once the technology is deployed, then they will be able to fully do that. And of course, capacity building around training. So we do a training of trainer model where we train the trainers in this COVID world. Now we experimented last year and this year remote trainings. And then all the training on the ground, particularly with ministry, is done by the ministry staff. So usually the ministry staff will not want us on the ground during the trainings. They will want to be able to do it independently. So that's what we've been focusing on, to be able to do assessments as well, online assessments, to ensure the quality of the trainers that are going to provide the step-down training is high enough. So, I mean, I could talk for a very long time about this, but I'm going to stop here.
Thanks a lot for answering that question. Next, Patrick Silborn, go ahead.
Thank you. Maybe my question was actually answered a bit. I was interested in understanding the implementation model, and if you see yourself as a tech provider and tech vendor, or if you sort of see yourself as doing much more than that.
Thank you for that. I think that was our fundamental question from day one of Simprints, and an internal debate in the company whether we are a tech vendor or an impact partner. So we are an impact partner. Even though in some partnerships, depending on the preference of the client, we can be more towards a tech vendor. If the client wants us to be a tech vendor, we are not going to enforce. However, in the majority of our programs, we are an impact partner. And we go in the project designing a partnership and supporting the client achieve their goals of the project itself. So one example for this would be in Ethiopia, we're doing the mass drug administration program where we provide biometrics to ensure the drugs reach the participants. In that program, we're as invested as all the other partners in the coverage targets of the programs. So we are actually held accountable on coverage targets for the program itself, not only if the biometric technology is used. We are responsible for the adoption of the technology, even for community acceptance of the technology, because we're in charge of designing the community sensitization, as well as the end goals of the project itself. So I would say impact partners. However, if they're clients who have a strong team on the ground that can do all of that, and they only want the technology from us, we will only sell the technology, as long as we trust the partner. So we always have a vetting mechanism in place.
Thanks a lot. Patrick Oseve, would you like to ask one more?
Yeah, just 3 quick questions. You mentioned that your work on COVID is because you've not declared the country. Would you be able to just share the elements of what you're planning to do without naming the country? Would you also just share very briefly what you do with Gavi? And lastly, you indicated that you're very much integrated with the district health information system. In many countries, the system doesn't work. So how does that integration really work? Thank you.
Yes, thank you for that. So the first one in the COVID-19, so the elements of the program are going to be, it's actually around the DHIS2 integration and implementation. So the project itself is a 3-year-long project, and it will involve it will involve the integration with the DHIS2 platform, and then distributing it for the verification of the COVID-19 deliveries. It will start with a pilot as well. We are, as I mentioned, traveling to the country to be able to understand exactly which areas, which districts we're going to start in, and also whether we're going to start with a certain category of people, whether we're going to start with the healthcare force actually as the first cohort of people being vaccinated, whether we're going to start with the elderly to design the pilot. Ideally, the pilot will be, and this is the discussions that we're having right now with the team on the ground. Ideally, we would be targeting one sector of the population across a wider region rather than across population and a smaller region, just to mimic to mirror pretty much what's going on in the country with the distribution. Sorry, that's not coming from me. The sound, apologies. For the Gavi partnership, so we have one project that we can talk publicly about, which is developing biometrics for children. So we've been working with these partnerships with Gavi and the Japanese company NEC since about 2 years now, developing biometrics for children. And we're now in the second phase of the project, where we are collecting 2 large data sets, one in Bangladesh and one in Tanzania, for children under 5. And developing the technology. And the next phase will be an immunization pilot, actually, in Bangladesh, that we are going to start next year after the technology is developed. And Gavi is also interested in the COVID-19 distribution work as well. So we are also now working with them towards that. And your third question was around DHIS2 implementation. And yes, I mean, it's always a challenge when the platform itself doesn't work. And usually what we do is when the platform is not established, particularly the tracker. So we are working on the Android side. So in countries where either the tracker or any other mobile platform is not yet working properly, we don't go there to complicate the things. So ideally, once you have a platform stable in the country, then is when you can add biometrics to it, because otherwise it can be depending on the local capacity on the ground, and that's critical, right? If there is local capacity, then we can think about introducing both in the same time. But when it's not, we are working to select a district or a place where the technology is working, that the capacity is there, and then we would be working on adding biometrics. But obviously adding 2 technologies in the same time when there is little capacity, the infrastructure is not there, would not be ethical from our perspective. So we try to always vet to see if the conditions for adding biometrics are there, both from a cultural perspective in the context, but also from a technical perspective.
Thank you, Alexandra. So time is up now, and that's the end of our Q&A session, also the end of our pitching. So again, thank you to all our teams for your pitches, especially in spite of the time zone differences for those of you who are very late at night or very early in the morning. So thanks a lot for participating today, and thanks to our judges for all the questions. It's now time for the deliberation. So the judges will deliberate in a separate room. And for the teams, you can have a break. So please rest a little bit for 20 minutes, have a drink of water, have a stretch if you would like to, and we'll be back in 20 minutes. So see you soon. Thank you. Everyone, thanks a lot for the wait. So welcome back. We're now nearing the end of this final event as all our judges are now back from the deliberation. So here now comes the award ceremony that everyone's been excited about. Before we move to the award ceremony, I just want to say that all the judges were really impressed with all of your pitches and all of your work. From what I've heard, the decision was really not an easy one to make. And at the end of the day, all your projects are amazing. I wish each and every one of you all the best. And as a matter of fact, the decision was so hard to make that we actually have 2 teams that were selected today. So before we do, we announce who the selected teams are, I would like to hand over to Mrs. Shireen Hamid, who's Director General for the Information and Technology Department at ADB, to give us a few closing remarks. So Mrs. Hamid, please go ahead. The floor is yours.
Thank you. Thank you very much, Sarah. Good morning, good afternoon, good evening, everyone. It's a great pleasure to be here with you. My name is Shireen Hamid. I am the Director General for the Information Technology Department for ADB. Congratulations to all of you who were selected to do the pitching today. We're happy to have had more than 97 solutions submitted from 367 participants for this challenge. And out of the 97 submitted solutions, the team selected the top 4 through a very competitive filtering process. The top 4 teams represent a diverse set of creative and innovative minds coming from different countries, from different professional backgrounds. I would like to again congratulate the teams. And here I have Reach 52 from Singapore, Team Simrins from the United Kingdom, Empower plus United Purpose from Bangladesh, and Team Johnson & Johnson Global Public Health from the United States. Thank you for making to the final stage of this challenge. You are already a winner by being here today. I would like to take this opportunity to share with you a little bit of background. We launched this Digital Against COVID-19 2020 ADB AIM Hackathon at the start of pandemic. In that time, we have hosted more than 15 challenges, engaged more than 2,779 participants with 1,325 teams, and have sourced 732 innovative solutions. We have seen the importance of remote technologies grow exponentially since then. All sectors from education to construction, transport to tourism are looking for new practices, as many of the old practices have become less relevant. In the new normal, it's less about copy-paste and more about create. As we all know, challenges push us to innovate. I want to thank you for your time and commitment for developing your solutions to support accountability and responsiveness of governments during the pandemic. Now, not only do we have a diverse set of winning teams, but we also have a diverse group of jury members. I would like to personally thank Robert Gill, Chief Sector Officer from SDCC, Patrick Osewi, our Chief of Health Sector Group from SDCC, Caroline Cabrera, our Principal IT Specialist, Julie Kay, Vice President and Executive Director from CLIC, Mark Landry, Regional Advisor, Health Information Systems from the Southeast Asia Regional Office in WHO, Andrew Schroeder, Vice President of Research and Analyst from Direct Relief, and Patrick Silborn, Regional Advisor from the Pandemic Action Network. Thank you so much for your time to judge this session. As this is the final challenge in our Digital Against COVID-19 2020 ADB AIM Hackathon, I would also like to thank my own ITD team for their hard work over this past year for the entire hackathon series. I am glad that it has been a resounding success. Again, congratulations to the selected teams and all the participants. Thank you for your cutting-edge ideas and solutions, and we look forward to working with you and our health sector group towards implementing a successful pilot in the coming months. Thank you again, and over to you, Sarah.
Thanks a lot, Mrs. Hamid. So it is now time for the results announcement and to announce the 2 teams who were selected today. So I hope you're ready, and I hope you're not too nervous. The selected teams today are the J&J Global Public Health Team and Reach 52. Congratulations to both of you. So, both of you, both teams, do you have some words? J&J team, do you have anything to say?
Well, thank you very much. We're very honored to receive this this selection. So we were happy to contribute to the challenge. Again, I want to also second the earlier comments. I think it was a great team of finalists that presented their solutions, and I'm quite confident that there will be connections made after this this hackathon with or between the different teams. But very honored and very glad that we are part of the final selected teams to engage in a pilot in support of COVID-19. Thank you very much.
Thanks a lot, Romain. And Reach 52, Ed, do you have anything to say?
Yeah, thank you. Yeah, a bit shocked. I saw J&J at the top first, and then I had to like look down to see Reach 52. But yeah, no, yeah. Firstly, I was just thinking as we were on the pause, you know, all four entrants were fantastic, and they're all complementary in a way. So you could have seen a world where, yeah, we all work together, and hopefully we do one day. But yeah, thank you very much for the vote of confidence, and yeah, really looking forward to getting a pilot live. Yeah, it really does mean a lot, and thank you for the recognition. And yeah, thank you.
Thanks a lot, and thanks to both our teams and also to all the other finalists. Everyone did extremely well, so you can all be proud of your achievements today. Now, just before we wrap this up, I'd like to ask everyone to put their cameras on for a quick picture time. So please put your cameras on. Our producer is going to take a few screenshots as a commemorative photo. So please say cheese and smile to the camera. And David, let us know if you have any instructions for us and when we're good.
Sure, thank you, Sarah. I'm still missing some cameras on. Just give people a little bit of time to turn on their cameras, put the best smile. I'll let you know once I'm gonna take the screenshot. So, all right, I think that will be everyone. Is still missing a couple of people. Let's give it 10 more seconds. Let's wait for Saki. He's arranging his camera, and after that, I'll take the screenshot. Okay, so 3, 2, 1, and just let me take one more. Okay, thank you. That's it.
Thanks a lot, David, and thanks everyone for smiling for the camera. You'll see those pictures up on the hackathon page later on. Well, that is now the end of our final event. So just to finish off, I really want to finish with a huge thank you for your fantastic work to obviously all our finalists and your active participation. And we hope, of course, that you're going to continue to develop and improve on your solutions, and that is valid for the teams who were selected today, but of course also for those who weren't. And I hope you'll stay in touch with us. If you have any questions at any point in time, feel free to reach out. Again, also I want to thank our judges who were participating today and made this possible. Also, thank you to all the team. Thank you to Mrs. Hamid for providing the closing remarks as well. So, and thank you to our audience who's watching the YouTube live stream today. So yes, thanks everyone for making this possible, and we hope you had a good time during this event. So, well, have a great day, or great night for those of you who are late right now, or good morning, and we hope to see you again soon, and please stay safe. Bye-bye.
Bye.
Thank you.
Thank you.
Happy Friday.